this place this day. We pray for all resource persons that will help them and grant them utterance. We pray for all who are invited for this program that will listen the steps and bring them to join us here. Lord, that at the end of this meeting, you have every cause to give you praise. Have your way, dear Lord. In Jesus' mighty name we have prayed. Amen.
This is the 5th edition of the August Bootcamp, and the Bootcamp is just centered on children with disabilities, cerebral palsy and focus, and we bring them together and we have Dr. Uchenna Oluwatosi, the HOD, Physiotherapy Department, FMC Hawaii. Please can we put our hands together for her? We have Engineer Godfrey Amarebuda, PhD, who is the co-founder of the Straight Child Foundation. Please can we put our hands together? Lots and lots of people, as they come, we will be introducing them. For you that is seated here, we are not taking it for granted. Please can you put our hands together for yourselves? I know some of us were invited. I'll get names and introduce you appropriately. Please, while we wait for that, please can DJ give us the interview.
I will start by introducing some of our invited guests that are around. And without further ado, please do well to put your hands together and encourage them. First of all, let us recognize Regions Healthcare Hospitals and Specialist Clinics. Please, can we put our hands together for them? They came with their team, which includes Dr. Kano Ngozi. Please, can you put your hands together for Dr. Kano Ngozi? Dr. Kano Ngozi, please, can you move over to the, we have a space here for you. Secondly, we'd like to introduce Mr. Akinsolu, the occupational therapist. Please, can we put our hands together for Mr. Akinsolu? Next on our list is Mr. Sotomi, the speech therapist. Please, let's still appreciate him. Ezesie Precious. Ezesie Precious is Ezesie Precious. Please, let's put our hands together for Ezesie Precious. Then Mr. Leonard. Mr. Leonard. Let's put our hands together for Mr. Leonard. They will be seated down there to do what they have been asked to do. Let's also Okonkwo Ijoma from Abia State Disability Commission. Please, can we put our hands together for her? Let's do it better. Let's not be stingy with the clapping. It's free. We're not paying for it. Let's do it better. Nancy Ijoma Madu, Abia State Disability Commission also. Please, let's put our hands together for her. Why is she not behind? Come to the front. Come to the front, ma. The last, for now, but not the least, let's recognize Dr. Chidomere, the pediatric neurologist, FMC Maya. Please, can we put our hands together? But let's not be stingy now. We know they pay for. They're not paying for the clapping. Let's clap. Dr. Uchenna Oluwatosi for her speech. Please, let's not be stingy. Those hands. Thank you.
Thank you very much. Good morning, ladies and gentlemen. So my duty is to let us understand who we are, the Straight Child Foundation, and how far we have come, and why we do what we do. So, I will read. Distinguished guests, respected facilitators, health professionals, ladies and gentlemen, it's with great gratitude and pleasure that I welcome you all to the Cerebral Palsy Seminar for Health Workers, organized by the Straight Child Foundation as part of our annual August Bootcamp for children with cerebral palsy. This year's Bootcamp is the 5th edition of its kind, a testament to our sustained commitment to improving care and support for children with disabilities and their families. When we started the Straight Child Foundation, the very first vision of this house was for children with cerebral palsy. to make life better for them as seen in other clients. And so, as we grew, we looked around to see how we can do this. And Benola Foundation used to have this kind of camp in Lagos, where they brought together health professionals to see these children, have an interaction and all that. And so we picked this idea from them and we have run with it over these years. And over these 5 years, we have reached out across the nation, inviting distinguished people in cerebral palsy care. We have invited Dr. Itwen from Calabar. We have had people like Dr. Anjorin from Ilorin. We have had a CP parent from Lagos. We have had speech therapists from Lagos. And today we have Regions Hospital together with Dr. Chidobere here. So it's been an interesting journey so far. We've not confined ourselves to our locality. We have spread our hands out to bring specialists to come and help us understand better how to care for those children. And that's what we're doing today. So who is the Straight Child Foundation? It's a registered non-government, non-profit organization which was established with the core mission of giving children born with physical disabilities a fair and equal chance in life. Our vision is a society where deformities, disabilities, and challenges, especially childhood disabilities like clubfoot and cerebral palsy, do not limit any child from attaining his or her God-given potential. Since we were established in 2017, we have supported the free treatment of over 3,500 children with clubfoot across 21 clubfoot clinics in secondary and tertiary health institutions within the Southeast, South-South, and North Central regions of Nigeria. We have also trained over 1,000 health workers in clubfoot and cerebral palsy identification, care, and referral, thus bridging a gap in healthcare delivery for children with mobility-related deformities. Beyond the clubfoot, which is right now like our clubfoot flagship program, because like I said, we started with cerebral palsy. Clubfoot came in, and then because we had good support, it seemed as if it took over. Like I said, more than 3,500 children across 21 clinics have been affected. But beyond that, our CP, we have also done something. We have provided over 23 assistive devices, including wheelchairs and CP chairs, to children with cerebral palsy. We have distributed more than 10 learning devices, smart laptop, children's tablets to these children. We have given 8 orthoptic shoes to aid mobility, and we have supported over 8 life-changing surgeries for these children. And we have initiatives like parent support groups, which holds, like the first speaker said, every other month. The parents of these children, they rub minds, exchange ideas, share problems, and somebody in the healthcare team could be a nutritionist, the last one was a clinical psychologist. Somebody will share something critical to the care of their children with them, and they will go home relieved and better, part of the burden they came with lifted or lightened. We also used to have the annual boot camp, and in the month of March, we normally have the CP awareness. And in that CP awareness, we've also brought people like Noyenweke of CP Center Lagos here, which ensures that children with disabilities in our partner facilities are protected from abuse and neglect. Crucial intervention is given to children with disabilities as they are twice likely to suffer from abuse compared to their peers. Today's seminar is part of our broader mission. We want to equip health workers with the knowledge, skills, and sensitivity needed for effective identification, management, and referral of children with cerebral palsy. Now, unlike previous years, if you come to our seminar, care approach that we normally would have done as part of the August Bootcamp in previous years, we decided to try out something different to see how effective it will be, because that keeps us for long hours and sometimes it's not so interesting anymore. So we decided to split and do that this year. So tomorrow and next we'll still be on this, but we won't be here. We'll be in the gym in our office with the children and the parents doing the practicals of what we're learning today. So what we want to do today is to help broaden understanding of cerebral palsy, causes, prevention and management, which Dr. Chidebere has done good justice to, promote early detection and intervention, strengthen collaboration amongst healthcare workers for better multidisciplinary care. We have brought the specialists from regions, which is a palsy care. So we want to break myths, we want to challenge stereotypes and encourage inclusive healthcare practices. So dear colleagues, the knowledge you gain today can change the trajectory of a child's life, turning the story of struggle into one of peace. So I urge you to participate actively, ask questions, share your experiences, take back actionable strategies to your respective facilities, especially those of us here in FMC Umuahia. We deeply appreciate our resource persons for sharing their expertise, but you chose to be here, so we really appreciate you. Let us remember that behind every child with a diagnosis, is a child with dreams, a family with hope, and a future that is worth fighting for. So, together we can create the world where they are defined beyond their disabilities. Once again, you are welcome, and I wish we have a more impactful seminar.
Good morning, everybody. Thank you very much for honoring our invitation and being here today for the special CP seminar for health workers. We're still expecting a couple of persons, just like the MC has said. We're hoping they can meet up as quickly as possible, since they are a bit busy in the clinics and with other activities. But without further ado, we'll start. And for the first lecture, we're going to be talking about the epidemiology and burden of cerebral palsy. Please bear in mind, I'm not one of the main speakers or one of the main guest persons today. So anything you see here, they're just going to be in summary. The details are going to be coming subsequently as to the stage. All right, so epidemiology and burden of cerebral palsy. So in the world, I think many a times when we go on news and we hear some form of diseases or conditions that makes the news, that makes waves, that attracts the attention of people, you almost always hear it in the line of an infectious disease, malaria, tuberculosis, maybe in the case of non-infectious disease, you can hear about cancer and the likes. But underneath these very little and few conditions that make the news or that make waves are a whole lot of other conditions that people don't even know about. That people know about but don't even know what it is exactly. Some people even know about it and know what it is, but they are still not well informed about these conditions. And one of those conditions is cerebral palsy. So introduction, cerebral palsy is a group of disorders affecting the movement and posture. If you say a baby or a child with cerebral palsy, the posture is almost always affected because they don't stand, they don't move, the parts of the body don't move, are not coordinated as you, that's normal. Okay, and this is caused by a damage that occurs to the developing brain, most often before birth. There are several types, include spastic, dyskinetic, ataxic, and mixed cerebral palsy. All of this will come in full details when the other facilitators come on board. All right, currently the global prevalence of cerebral palsy in the world is about 1 to 4 babies per 1,000 live births. So in every 1,000 babies that are born in a year, you have a possibility of having a child with cerebral palsy in 1 to 4 of them. In Nigeria, cerebral palsy affects approximately about 2 to 10 babies per 1,000 births. So if you have 1,000 baby born in Nigeria today, there's a good possibility you have between 2 to 10 of them with cerebral palsy. And this range, or this statistic, ranges from different regions. There are some regions in Nigeria that may have 2. Some regions in Nigeria may have more than that, depending on where the number of births occur. And the causes of this cerebral palsy are very much linked to cases like premature birth. Organs of the body, of the baby's body, have not been well developed, including the brain. All right, lack of prenatal care. Many of these parents, even while they are pregnant, don't come for prenatal care where they can be advised and told on what to do while they are still pregnant and what to do even during and after pregnancy. Central nervous system infections, which include meningitis, the infection of the meninges that causes inflammation in the meninges, sepsis, infection of the blood, as well as other birth complications. All right, in other countries, you could see that the possibility of children having been bedridden or not leading a good and purposeful life is quite limited compared to the ones that we have in our vicinity here. Why? Because most of these children are already are diagnosed for this particular condition called CP. So that in Nigeria, many children are diagnosed with CP after the age of 2. So, and even at the age of 2, some people still don't even go to look for remedies or look for treatment or management. They'll start looking for traditional, quote-unquote, health workers. They start looking. The rate of the occurrence and prevalence of this condition is quite high, even in our region here in the rural than in the urban areas. Now, what are the risk factors of this condition? Let's talk about maternal health. The maternal health significantly affects the newborns. And the maternal health here is the health directed at the mother of the baby or at the mother of the children. And here, poor antenatal care. If the mother does not have good antenatal care, good antenatal education, they may not know what to do part-time, they may not know what to watch out, the signs to watch out to know if this baby is going to have or has cerebral palsy. Malaria in pregnancy. Malaria in pregnancy can affect the central nervous system of the baby, can go through the umbilical cord and affect the baby. Hypertension and preeclampsia. Delivery factors. Prolonged and obstructed labor could be a risk factor. Home birth without skilled attendants could be a risk factor. We also have poor neonatal care practices can also increase the prevalence of CP in children. And this can be seen in cases of children having severe jaundice, infection, and hypoglycemia. So the burden of CP. Health burden, number one, we don't have enough health facilities that are well equipped, not just with facilities, equipment, but even with staff and health workers that are trained. At the same time, even in children that have CP, there are also some coexisting conditions like epilepsy, speech impairment, and feeding difficulties. All increases the burden of CP. We have socioeconomic burdens. Socioeconomic burdens can be seen in high cost of high pocket expenses because the management of CP is not cheap. So it's going to have a socioeconomic burden, not just on the parents, but even on the society at large. Parents may be forced to stop work. Some babies with CP can be totally dependent on their parents. So they have to stop work to take care of them. Some of these babies with CP have low or no accessibility to education systems because some schools not even be able to take care of children with CP. Some schools are not even well built or established in a way that can take care of children with disability. So they are not able to even. Now we also have stigmatization and also different perceptions in society because of poor information or misinformation. Stigma around cerebral palsy often leads to social isolation for affected families. Some people don't want to relate to families that have CP. Even currently, some people even think that CP is contagious. So if you're a mother or a father with CP, they don't want to relate with you. Sorry, if you're a mother or a father with a child with CP, they don't want to relate with you because they don't want their children to play with you or with your children. We also have some cultural beliefs that also increases the misinformation of CP and misunderstanding of CP in our society. Some people around here also believe that CP is as a result of one of the social vices that the mother must have engaged in while she was pregnant, or because of one traditional belief, maybe the grandfather of one generation ago placed the curse on the family and said this is what is going to be happening in the family for as long as the family name is in existence. Also, we have discrimination in education and employment opportunities. There are so many people with conditions like CP as well as other disabilities who don't have access to education and who don't have access to equal employment opportunities compared to other people. Now, mortality, life, and expectancy. Individuals with CP in Nigeria face significantly reduced life expectancy compared to peers in other parts of the world. Why? Because these people in other parts of the world have access to healthcare. Before something happens to them, there's already somebody there who has the pointers, who understands what the person is going through and is able to nip it in the bud and take care of them. At the same time, mortality often occurs and are preventable, but often occurs due to some complications like malnutrition. In this part of the world, some parents don't even know how to organize and arrange the nutritional needs of their children with CP. So many of the children can die because of malnutrition. Some of them die because of respiratory infection, and some of them also have seizures. Now, the intervention and recommendation. What are the intervention and recommendation that we are going to be putting forth today? Number one, early diagnosis. It is important that these children are diagnosed as early as the first 6 months of their birth, so that you can start planning on how to help them live better lives. Also, we need community-based programs that facilitate awareness and support for affected families. There are some, currently in Nigeria, we don't even have a good community base to support children with CP. Talk more of their families and what they go through. So we need a community-based program to help support the children and their families. We also need intersectoral collaborations in the developmental sector that can put forth policies, that can put forth and enforce policies rather, to help improve the lives of children and the families that have children with CP. At the Stretcher Foundation, what do we education here? These are the things that we do. Number one, we aim to educate, not just aim, as we are aiming, we are educating. So if we are educating 100 persons today, we are hoping to educate 1,000 persons tomorrow. So we aim to educate communities about cerebral palsy, and currently we provide physiotherapy for free at our gym in our facility. Secondly, we provide resources and support to families affected by CP. Currently in the Stretcher Foundation, we have a community of parents with CP, and we call them together every other month and invite a facilitator who can spread aspects of cerebral palsy care that they can replicate at home to these children to help them live better lives. TSCF also advocates for better healthcare children with cerebral palsy. You could see among our invited guests here were a representative from Abia State Disability Commission. Aside from this branch of government, we also have good talks, or we have good talks rather, with the Ministry of Poverty Alleviation and Social Protection, Ministry of Women Affairs. Even right now, our information is on the table of the wife of the governor. So we, as Cerebral Foundation, are also trying to find a way to bridge the gap between parents and children with CP and the government, so that they can be seen, they can be known, and policies that can be made around them. In conclusion, effective intervention requires a collective effort from healthcare professionals. Without the healthcare professionals knowing about these conditions, knowing about the depth of information, as well as facilities, as well as skilled workers in the field, we will not be able to make any headway in bringing healthcare to these children with CP. We also need community awareness and support. We need people to know about this condition. We need people to know that this condition is not a death sentence. We need people to know that this condition is not contagious. People with CP can get good life, can lead good life. I don't know if any of us have watched this series called Breaking Bad. Have you watched this series called Breaking Bad? This man that was cooking up cocaine in a particular lab for a couple of years. There was this particular guy in that particular series, the man's son that was on crutches. That guy in real life has CP. But on that show, you wouldn't know he has CP. He's living a very good life. Why? Because number one, he got early intervention. Number two, there's a community that supports him, that supports his growth as a human being, not as a CP patient, but as a human being, and he's living his life. He's one of the top Hollywood actors currently. Then we need collaborating initiatives that will foster and better improve the understanding of people around us and reduce the stigma around CP. Thank you very much.
We're taking notes. Subsequently, questions go there. We would like to, I think at the end of the program, we would like to have a recap of the things that we've talked about. So please. for us not to, if you have your questions, you can put them down so that you can ask your questions much later.
Good morning, everyone. I wish to thank everyone and as well the organizers for inviting me to be part of this awareness program. Thank you very much. This morning I'll be speaking on how we can optimize the neurological outcomes of children with cerebral palsy through early diagnosis and intervention. And I'm going to take the discussion in this order. At the end of this discussion, we'll be able to know what cerebral palsy is and the management, the challenges of management and potential solutions and strategies. We're also going to know the importance of early diagnosis and intervention. But before I'll proceed, I would like to define some terms we might encounter in the course of this discussion. We, see this word anytime we discuss disabilities. Brain defects. When we talk of brain defects, what do we mean? It means irregularities in the brain structure that can cause impairment. When these irregularities result from abnormal development, it is called malformation. When it results from insult or in disease or infection, it is called brain lesion. And that brain defect, that irregularities, once it impairs the function of that region of the brain or that portion of the brain, it is impairment. So, impairment. Because there will be loss of function of that particular part of the brain, that region of the brain. And the functional consequence of the impairment is disability, because that will hinder the person from carrying out certain activities, that is activity limitation, and interacting with the world around him or her, that is participation restriction. And the disadvantage experienced in the society by that individual is handicap. Now, what is cerebral palsy? According to the International Executive Committee on Cerebral Palsy, it is described as a group of permanent disorders of movement and posture, causing activity limitations attributed to non-progressive disturbance in the brain occurring early in the development. Whenever I discuss cerebral palsy, I normally like to emphasize on the key information in the definition. There are 4 key informations here. Number one, it is a permanent disorder. Once you tag somebody cerebral palsy, it's there. It doesn't change. I mean, the person, you cannot tomorrow say the person doesn't have cerebral palsy anymore. No. But the person can improve in the functional ability. But once that cerebral palsy is established in that individual, it's there. So it's a permanent disorder. The next key information is movement and posture. It is a disorder of motor function. Motor functions are the functions we carry out with our muscles. Movement, posture. You can see the way I am standing. You can see my movement. That is my function, motor function. And the cerebral palsy affects motor function. The next is attributed to non-progressive disturbance. Whatever that causes it doesn't progress. So it is not a degenerative condition. The way that person is today, well, if you manage the person can improve, but the person cannot go down. So it is not a degenerate. It doesn't get worse over time. And it occurs in the developing brain. Only developing brain. The brain development, brain growth, the peak is within the 5 years, first 5 years of life, starting from when the child is in the womb. So after that, for example, at the age of 7 years, if there is a child suffers non-progressive injury to the brain, and comes down with motor deficit, it is not cerebral palsy. So it must occur within the time the brain is growing. Even though it's a permanent thing, that is when you call it cerebral palsy. It is a neurodevelopmental disorder that begins in early childhood and lasts throughout life. It is the most common chronic motor disability in children. You can see them. In Nigeria, it is the leading cause of childhood neurodisability. It is not a degenerative disorder. I've mentioned that earlier on, and so it doesn't get worse over time. It is not contagious and not hereditary. We see a lot of them in clinic when they come. First child, because the child has cerebral palsy, the woman she won't be in a hurry to take in again because she's scared. I'm suffering this way, just one. How much more when there are two? When I have them two? Do you understand? So they are scared. So with this, we also like to use this opportunity, to educate people, tell them that cerebral palsy, it's not a hereditary problem. That you have it does not mean that the subsequent children will have it. And it is not contagious. You see them, you run away from them because they are not really good looking. You don't want their body to touch you. It is not contagious. These children, they face other added problems. They are stigmatized. Like I told you, there are most times they are not, because it's a motor problem, that they have deformities. People run away from them. They are stigmatized. They are not, remember I told you, participation restriction and the activity limitation. So they are restricted from participating in certain activities. They are malnourished, some of them, especially those that have severe type. And poor feeding, ignorance in feeding methods by the caregivers can cause malnutrition in them. Inadequate facilities for rehabilitation, like the diminished educational opportunities, abandonment due to caregiver burnout, because we don't start early. At 10 years, 15 years, you're still carrying a sick child because you didn't start early to do the right thing. So at 15 years, this child cannot walk. It's still immobile, so you're carrying the child. At a point, you're fed up, you're tired. I can't continue lifting this child. Burnout setting, and that will lead to what? Abandonment. And when you abandon them, they are more likely to die. And the static lesion in children with CP cannot be reversed. Therefore, managing children with CP focuses on addressing motor impairment and associated morbidity. We shall see that. Early identification, intervention are crucial in the management of children with CP, as addressing this early identification and management will at its earliest stage, we facilitate neuroplasticity of the brain. We shall see this move. Do I still have to waste my time in prevalence? Epidemiology has already discussed that. It's in Nigeria, it's not only in Oma here. Of course, you can see the prevalence is more in the developing countries. In Nigeria, most recent studies on prevalence are hospital-based, and it is estimated to account between epilepsy. It is the most common neurologic condition we see in our clinic. Etiology. Cerebral palsy is caused by brain injury or malformation. This is the diagram of the brain. This is the part of the brain, the cerebral cortex, where voluntary movement is initiated. And it is refined here in the brainstem, and the basal ganglia and the cerebellum. You can see, if I want to move, I initiate it and move. Do you understand? If I want to sit, I'll sit. My cerebral cortex is functioning. I'm standing, I'm not shaking, I'm not falling. The part of the brain responsible for that are functioning. Cerebellum, especially for coordination and balance, they are intact. So what happened? Insult, I told you, is a non-progressive insult. We attack this part of the brain. It's either the movement is not initial voluntary movement or it's not refined, and that's why you have that spasticity and that involuntary movement. So this is where the problem, and this damage must occur either when the child is still in utero or during the time of delivery, perinatal in the first week of life, and up to after birth, up to 5 years when I told you brain growth stopped. When you give birth to a child, at birth, the brain size is just 1/4 of adult brain. By the time the child is celebrating his first birthday, it's half. By the time the child is celebrating his third birthday, it's up to 85. By fifth birthday, it's almost 100%. So beyond that, we don't talk of brain. So that damage must occur within that period. The brain is doing what? Growing when you target cerebral palsy, and that's why it must occur before, during, or shortly after birth. Why the precise cause is often unknown. You take the history, everything, you will still not find, what to link the cause of that CP in that child. Variety of factors can contribute. Brain malformation, this genesis. Remember, I told you about lesion when it results from abnormal development, it's malformation. Hypoxic event like hypoxic ischemic encephalopathy, ventricular malacia, that is damage in brain around the white matter area, intraventricular hemorrhage. So that's when there's lack of oxygen to the brain, or bleeding, or infection. This can affect the neural pathway that carry information. The nerves are like electric wire, insulated electric wire. You insulate those, and there will be refined electric current, flow of the electric current. Like if it's not insulated, there will be dissipation, and if you touch it, you might get electrical. So the same way, neurons, they are myelinated. Those myelin sheets, they help to, ensure a smooth neural movement of neural information. So when there is damage to this axon, that's myelin sheet that cover the axons, the information dissipates. So you have a smooth transmission, and that will lead to manifestation you will see physically, depending on the part of the brain that is damaged. But now we are discussing the part that controls what? Movement. I told you, movement are the things you do with your muscles. So these are otherwise, in the majority of cases, the cause is not usually known. These are the risk factors. I don't have to waste my time. He's already mentioned the risk factor, the previous speaker. But it's important we know that in our environment, the implicated risk factors are bed asphyxia, neonatal jaundice, infections like central nervous system infection. So you see mothers, the babies have jaundice, the neighbors will tell them, don't worry, go and give ampiclos, give glucose water. Please, those things don't correct. They are not remedy. The best, neonatal jaundice is a medical emergency, no matter how small it is. So take that baby to a neonatologist or a pediatrician, and sample must be collected. There are other contributory factors like ignorance, poverty, poor health-seeking behaviors, the side of the caregivers, poor health facilities, lack of skilled manpower. Class based on the motor abnormality and the functional ability. The measure you're not even saying. The motor classification is based on the muscle tone. It's the most time they are stiff. That is hypertonia. They are stiff. Some of them have flaccid paralysis, but majority of them is spastic. It's spasticity you will see. The next is anatomical distribution. The parts of the body involved: one limb, one side of the body, the entire body. Then functional classification. using various functional classification systems. This is to ascertain what the child can do, and depending on the degree of intervention given. So we stopped at the functional classification. The functional classification helps in predicting prognosis and services required for rehabilitation, and is graded from level 1, where the affected child is fully independent, to level 5, where the child is fully dependent. So there are 4 major types of CP. These are the 4 major types. So let's use this pictorial. So these are the spastic. When the damage occurs primarily at the cerebral cortex, the hemisphere, the part of the brain that's where I told you involuntary movement is initiated. You see the types. This is hemiplegic, one side, anatomic distribution I told you. So when it affects one side of the body, it is hemiplegic, and you can see this extent of damage. That's where the voluntary movement, cerebral cortex. And you can see how this one is flexed more than this. So when you talk of hemiplegia, upper limb is more affected than the lower limb. This is diplegia. See where the damage is. And you see this is darker. The color here is dark, the entire limb. I can see the extent of damage. Now, these other ones, the damage is not here, but where the movement is already initiated is refined. So, but because these ones are not functioning, gauge, that's ataxic and dystonic type, dyskinetic type, sorry. They have other associated problems. Like I told you, the primary problem is motor, but in 25 to 85% of them will still have associated conditions like impaired speech, epilepsy. Studies have shown that epilepsy is the commonest comorbidity. From our own study, Chidomere et al., speech and epilepsy, where the common comorbidities were found in these children. And these are other comorbidities. Clinical features, how do they present? Developmental delay. There are 4 domains of development, but the one motor domain is one that is majorly affected in children with cerebral palsy. So they'll come down with delayed motor function. They'll have abnormal tone, muscle tone. Like I told you, it's either is stiff or is flashy. Most times they are stiff. Preference for one side of the body. When you see a baby, the baby is always moving one side. Suspect cerebral palsy in that child. Difficulty speaking and swallowing due to what? Still muscle abnormalities. Saliva drooling, they cannot control because the muscles involved in deglutitions, they have problems. So the secretions are accumulating, and such type, they also have feeding problems. Learning disability. These are the major type, like quadriplegia. Quadriplegic CP is the most severe form of cerebral palsy. You can see this one. This one was not poorly managed. Probably there was no early intervention. You can see here, you see there's already contraction. The legs are already folded, the hands are already folded because there was no early intervention, and it will be difficult for this child to move. Although the type this child has is severe type, the type that affects all the limbs. Still, the same patient, this patient with similar type, quadriplegic type. So this type is more severe. It affects the entire limb. They have cognition problem, speech problem, feeding problem. Seizure is more in them. Epileptic seizure more in them. Growth impairment and visual abnormalities. This is a hemiplegic type. These are about the mildest of them all. Affect. Of course, when I showed you the extent of damage, you see it isn't just a little portion. So this affects one side of the body, with the upper limb being more affected than the lower limb. Impairment, cognitive impairment is seen in just 1/4 of them, 25%, and epilepsy in 1/3. Diplegic CP, this affects primarily the legs, causing muscle stiffness, tightness, with minimal risk for seizure, learning disability, and impaired vision. The one that occur or result from lower part of the brain, not from where the movement are refined. So this is kinetic. You can see the abnormal movement. They have posture abnormality because of the abnormal contraction. As I'm raising my hand, the muscles here are contracted, these ones are relaxing. But in their own, this will as well be contracting, this one will as well be contracting, and that as such you now have abnormal posture. That is how they develop abnormal posture. And you see some involuntary movement because the part of the brain responsible for that is damaged. Some of them cannot walk, don't have good balance. Those that have the insult are the cerebellum, the part of the brain responsible for balance and coordination of movement. That will give you this type of CP, ataxic cerebral palsy. They may not have cognitive problem, remember, because the cerebral cortex, the insult is not there. What is the diagnosis of cerebral palsy? The diagnosis is essentially clinical. When you see a child with motor problem, of course you don't need any diagnostic investigation to confirm that, and there is no pathognomonic signs, to say that this is cerebral palsy. From the history, as you're evaluating the child, you will get the history of exposure to risk factors. Remember the risk factors we mentioned, you might get that. But however, remember I told you, in most cases, you may not see the cause, or even any risk factor. So there will be motor, when you do the motor assessment, of course, you'll be able to know the degree of motor function. You classify the patient and the functional, both motor and the functional severity. Then these are other investigations we need. Brain neuroimaging, MRI is the gold standard. Other, like I told you, they have comorbidities. So depending on what you found in that person will determine what to do next. For example, epilepsy is among the common, if not the most common comorbidity. So EEG will help you to handle that one. Another genetic testing. The management of cerebral palsy is geared towards, one, we want to minimize progressive deformity. I told you it's not a degenerative condition. It doesn't get worse over time. So whatever you do for this child is geared towards minimizing progressive deformity, manage associated problems we've just mentioned, improve child's functional outcome, and maximize independence to achieve a long, healthy life. Our target is not to cure cerebral palsy, but you can manage them and still bring out that potential in them, as we shall see later as we progress. So these are, because of the complexity of the problem, the management is multidisciplinary. And these are the things we need: the drugs, surgery, therapies, support, and then counseling. The healthcare professionals involved in the management of this, I told you, is multidisciplinary. Pediatrician and pediatric neurologist is important. I'm a pediatric neurologist. We stand in the center well, in the center coordinating, because they will first of all come to me as a pediatrician, and also I will also carry my function as a neurologist. Any medical thing I can do for this child, I will also do it. And as a a pediatrician, I play 3 roles. 1, as a physician, as an advocate, and then a coordinator. I'll coordinate other healthcare professionals. Then physiotherapists. This is the mainstream of treatment. It is a motor problem. So I guess physiotherapists are here. There, I can see one. So this is a motor problem. Most of them, the cognition is intact. The problem is motor function. If you apply early intervention, you get them. You can still get them. So this is the role of physiotherapy. They involve in exercise to improve movement and overcome weakness. Remember, the muscles are stiff. That they are stiff doesn't mean that they are strong. Do you understand? If you want to give somebody a blow, you first of all do like just to tense your muscle. Their own muscle is there, it's stiff, but it's weak. It can't do anything. So the role of physiotherapists is to help them to improve the functional outcome of the muscles and prevent pain. When you allow them without doing anything, over time, contractions set in. The tendon becomes so stiff that they can't even stretch their hand. And on attempt to do that, they'll start having pain. And they are not immobile, they don't even come out. So they're not getting vitamin D. Remember, the richest source of vitamin D is sunlight. Even if you live in American White House, your vitamin C is just 10%. 90% is still from sunlight. So these children are always indoors, they don't go outside. And vitamin C helps in absorption of nutrients required in bone mineralization like calcium and phosphorus. So when those things are lacking, the bone will be soft. On applying pressure, the person feels pain. So most time they are in pain, especially those that have severe type of CP. Occupational therapists, I'm glad occupational therapist is in our midst. He's going to tell us what they do. Well, they help these children to perform their everyday tasks. Speech therapist is also in our midst. They address the speech issue, as well as he's going to talk to us today. We'll learn more on the services they render. Orthotists, they are healthcare professionals. They make and feed braces and splint to help these children improve their movement and their gait efficiency. Nutritionists, they use their scientific food-based approach to evaluate the dietary requirement of these children. And depending on the severity, the food must be in a form that the child will be able to tolerate it. In some cases, oral feeding through the mouth might not even be possible. So in that case, you need to move further, make an opening through the abdomen and feed them with a feeding tube, gastrostomy tube, G2, to feed in order to optimize the nutritional requirement or nutrient. Orthopedic surgeons, our dear Dr. Peace is really doing great in that area. So we need them. Their role is to correct. The aim of this gathering is to emphasize what to do so that these children will not get to this stage of having the need for the orthopedic surgeon to intervene. When you do the right thing early through physiotherapy, orthopedic intervention. The caregivers are also involved in the care of these children. They administer drugs, dress them, care for them at home. And so their role is also important because we need to promote the physical and well-being of these children. And psychologists for both the caregiver and the affected children. Other treatments required are this. Let's not waste our time. The rehabilitation approach to improve the functional motor function of these children. The prognosis of cerebral palsy is extremely variable. Good outcome is seen on adequate medical care, early interfamily support. Poor prognosis depends on severity, and life expectancy is normal for the diplegic and the one that affects the legs and one side of the body. Mortality is recorded more in this body. However, this woman, Bernadette River, she lived with cerebral palsy for 83 years. She died a few years ago. Severe type that at the age of 75 was the first time she was able to operate electric wheelchair. So it means that when you start early, that child can still live long. There are challenges we encountered in management of cerebral palsy. Limited resources. Due to limited resources, diagnosis is often delayed, like first speaker mentioned, especially in this part of our environment. In pediatrics, there was a few months ago, a woman brought a CP child at the age of 15 years. She came with two ladies helping her. This person will come. When you get tired, another person will help her with contraction. If you say the size of the child, looking like maybe a 7-year or a 5-year-old child, because the right thing was not done at the right time. So when it is delayed, there's a risk of missing the critical window for early intervention. Cultural belief, like the first speaker stated, some of them, they have these children at home, but they hide them because of the cultural belief. They don't want to be identified with children with this disability. Some of them believe that these disabilities are as a result of maybe the sin they committed in the past. So they don't want people to know through these children, so they keep them at home. Limited access to resources. Neuroimaging, you send some of them, when they manage to come, you request for investigation, they will still not be able to do them because of what? Financial constraint. Lack of trained, specialized neurological assessment tools and trained personnel are also scarce. Poor distribution of intervention services. You can imagine. Whole FMC, we don't even have a speech therapist. And I told you from our studies, the speech is one of the most common comorbidity we encounter in them. Yet there is no speech therapist. So most time, even when these services are available, they are what? Limited to what? Urban areas, or where we can make more money. And where the burden of the problem is, and assess these resources. Now, how do we come out of this problem? Let us first of all look at neuroplasticity. What is neuroplasticity? Neuroplasticity is basically the ability of the brain to change, reorganize, or grow neural networks. It allows for some adaptation and compensation in the developing brain. There are two types of neuroplasticity. The functional type, when the function of the part of the brain, damaged brain, is moved to undamaged area, and that is the functional plasticity. The structural one is the ability of the brain to change its physical structure, in response to in order to learn a new experience. Now, let's also understand this neuroplasticity very well. When you are born, or when a child is born, the number of neurons that child needs to grow in his or her life, they are complete, about more than 80 billion neurons. They are intact. But what is not there is what? The connectivities. So they can't do anything. But over time, you discover that child will begin to learn certain skills, isn't it? You've not asked yourself why. If you are told that this person has given birth, you just go there, you see a baby. The next month you go there, you see the baby moving and smiling. Hey, the baby smile. You've not asked yourself why. Who taught this child how to smile? That's the point, and that is through neuroplasticity. The nerve connectivity, those nerves that are there. As the child now comes out and is growing, the synapses are the gaps through which neural information are passed on. I just brought this one out. This is one neuron. Now, it has to synapse with another neuron. For information it has to pass it on to this. And it's through this synaptic gap. Are you with me? So at birth, one neuron has like about 2,500 synapses. This one single neuron like this. You see, you can see 1, 2, 3, isn't it? One can have to. By the age of 3 years, they are about 15,000. Ready to pick information. So when information comes, this is presynaptic neuron. These are neurotransmitters here. The information will cause this neurotransmitter to be released, and those neurotransmitters will bind on the receptors on these postsynaptic neurons to open ways for the information to pass on this wall. The information continues. Do you understand that? Now, so by the age of 3 years, there are about 15,000 synapses. So as you are growing through experiencing, some of these are being strengthened based on the experience you acquire. The ones that adamant are not functional will be removed through what? Synaptic pruning. And that's why as you're growing, they are reducing. We used to think that by the age of 25 years, development stopped. But in the recent time, it's not so. It continues even when there is damage. So the ability of the brain to reorganize, change its structure in order to adapt and compensate for that damaged area. That is when there is damage. But for the growing baby, through experiences, this the child, these neurons will be strengthened, this synaptic gap will be strengthened to code those information you place on that child. So that's why we speak on early intervention. When you start something early, you are bound to recover these children quick than when you allow them to continue to grow. Remember, like as they're growing, these synapses are being removed because they are seen being adult, they're not doing anything through pruning. But when you start doing something early, they will be engaged instead of being removed, so they will be used. The damaged areas, function might be moved to undamaged areas in order to improve the child's efficiency. So these are the conditions. So neuroplasticity helps to learn new things, enhance existing cognitive capability, recovery from the brain injury, and strengthen the areas where function is lost or has declined. Neuroplasticity plays a significant role in the concept of cerebral palsy. For early intervention through physiotherapy, occupational therapy, speech can promote neuroplasticity and improve outcome through adaptation and compensation. So for the early diagnosis, so what do? We need to identify these children early and bring them out. Improve program into community health systems, very important. Just like the Stretch Health Foundation is doing, is late presentation, so that when they come early, we get them the way they should be. Training the community health workers, encouraging charity organization, because most time they find it difficult to come because they are looking at their pocket. How much do I have? I'll be asked to pay certain amount which I don't have. Healthcare, there's need for collaboration and coordination, like the first speaker mentioned. Make available and affordable these resources, not physiotherapy being around or occupational therapists being around. Are they affordable? Can these children, remember, most of them is common among lower socioeconomic class. So we have to make it, even if they are available, the rate they can be, make them affordable for these children to benefit from those services. They're raising awareness and reducing stigma. Thank you, Stretch Child Foundation, for the advocacy. When people understand all these things, you see that they can't hide these children inside anymore. They'll bring them out. Government also has a role to play. Enact law to checkmate quackery. Some of these children, women, when they are pregnant, I'm also speaking on prevention as well. The world is moving towards prevention. If you don't prevent, they will flood the clinic with CP. We have to start from prevention. So checkmate the role of these people. Most time, these women, remember I told you, lower socioeconomic class, they will go where they will pay less money. So, and as such, they'll end up with this problem. Funding healthcare facility to ensure that these interventions become affordable. The importance of early diagnosis will help for early intervention that can significantly improve the child's motor skill. We have a lot of testimonies in our clinic. A lot of these children that have really improved in their motor skills. Reduce long-term need, empower families. So early diagnosis and access to support services can empower families and reduce burden of care. By addressing challenges and implementing evidence-based strategy, it is possible to improve early diagnosis and ensure that children with CP receive the timely support they need to thrive very well. You see, there are some celebrities that have really proven indeed that there is ability in disability. Probably interventions started timely. They had timely intervention. This is an American actor, a cerebral palsy. This is Dr. Ali Jelani. He's a Pakistan-born medical doctor. Is it this same hospital he's working? This same hospital. As a child, he was in and out of this hospital as a child. As a CP patient. But today, he walks along the hospital hall as a medical doctor, a cerebral palsy patient. So early intervention can still bring out the potentials in these children. So, this Miss Laura, in 2008, she's a cerebral palsy patient. This an artist, American artist, as well as a motivational speaker, a cerebral palsy patient. This woman, she's a Nepalese. She writes with her left foot. This is dyskinetic. Remember I told you, despite the fact that the whole body is involved, their cognition is intact because the major problem is not really from the cerebral cortex. I'm almost done. They're not hearing me. Okay. So this is Dr. Ajay. This is a Nigerian lady. She's a lawyer. She holds a master's degree in law as well as international law. She is a cerebral palsy. So, in conclusion, cerebral palsy is a life-limiting disorder without care and no identifiable preventive therapy. It is a disorder that occurs during the peak of neuroplasticity in the brain development. Therefore, any diagnosis and timely neurodevelopmental treatment can influence brain development and optimize neurological outcomes in children with cerebral palsy. Thank you very much.
Rehabilitation, Women Affairs, one call Felicia. Please, can we put our hands together for her? Okay. Please, let's put our hands together for her properly. Let's also recognize Mommy Regina Okonkwo. Mommy Regina Okonkwo, is she here? Okay, yes, she's here. Please, can we put our hands together for her? Let's also recognize Miss Maureen Dean, All Facts News. All right, we are here to cover the event and add them later. Let us specially recognize the DNS FM Sumaya, Honorable Silverly. Please, can we jam those hands together? Let's jam those hands together. All right, let's also recognize the NUJ Chairman, Abia State Chapter, Mr. Asonye. Please, let's put our hands together for him. And last but not the least, let us also recognize Mr. Eric Onombo, a clinical psychologist of MCMI. Now, at this point in time, we also want to recognize the founder of the Straight Child Foundation, the person whose vision we are treading upon at this point in time. Please, can we put our hands together as we recognize Dr. Peace Amarola? She walked in while the lecture was. But can you just? Okay. We are going to have the speech therapist, Mr. Sotomi, speak to us at this point in time. So can we put our hands together for Mr. Sotomi as he makes his way to the stage? Don't stop clapping until he comes to the stage.
Good afternoon, everyone. I'll be talking about the speech and language management in cerebral palsy, like the first speaker said. Thank you, Ma. So, as we know, speech and language problem, CP children, most of them, 70% comes down with that. So, we have to go through the slides and then, outlines, introduction, overview, speech language management, evidence-based and completion. So, palsy describes a group of permanent disorder of the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbance that occur in developing fetal or infant brain. Like she said, so I will just be standing on the existing protocol. So it's a non-progressive one. Once it happens, it happens. You can't tell a child that this child is children with or child with cerebral palsy and the following day you say, okay, the child does not have that again. No, it is not done. Once it is time, it is time. So, and what we see as the manifestation is physical, disturbance of sensation, perception, cognition, communication, behavior, and by secondary muscular skeletal CP. Children with CP often experience speech, language, and communication difficulties due to impaired motor, cognition deficit, or sensory impairment. Communication difficulty varies based on the types and severity of CP. She rightly said about the types, we were able to see the types, and then so it depends on the type and severity. That is why we're able to know that okay, this child is having this type of speech and language impairment. Some might not be having speech and language impairment while they will have swallowing difficulty as well. So now the children with spastic quadriplegia and those with co-occurring intellectual disability or hearing loss, communication challenges significantly affect quality of life. It's just like we as an individual that we are not with cerebral palsy and then we want to talk. We know how frustrating it might be. So compared to those with cerebral palsy, for years they have been neglected. So it can actually cause frustration, emotional frustration, and reduce independence. So etiology and risk factors based on communication challenges. Like we know, cerebral palsy, after it happened, it has to come with other comorbidities. She has rightly said all this. So we need to look at the speech subsystem affected in cerebral palsy. So we'll only be talking about the four aspects in speech production. We have the laryngeal system, we have the resonatory system, and we have the articulatory system. So regarding the respiratory system, we know the respiratory is actually, the lungs is used for the inhaling and exhaling of our air. So when these cerebral palsy find it difficult to extend their speaking, that is fatigue during extended speaking tasks, they feel tired while talking. These are the result of the lungs. So we also have the laryngeal system, that is the phonation aspect. Now, monotone speech, monotone pitch. For example, someone wants to say, I am happy, I am sad. So it comes out the same way. These are the things we can see: harsh or strained vocal quality, short pacing due to. So we also have resonatory system, incomplete or premature velopharyngeal port closure, nasality in speech. Some of their speech comes out through their nose, especially the consonants. So we also have the articulatory system, the labial sound, easiest, dental and glottal most difficult. Nasal least affected, the fricative and glass most challenging. Difficulty across all parties when they want to verbalize some sound, they find it difficult. And this might be as a result of this, of the articulatories. We have the tongue, we have the jaw, we have the teeth, we have the uvula, we have the... Okay. So we have the tongue, we have the jaw, we have the lips, we have the teeth, we have the alveolar grid, we have the hard palate, we have the soft palate. So all these can also affect the output. Also, I'll just moving down to management, speech and language management. What do we do as speech and language therapists? The first thing is that we do comprehensive assessment. While looking at the child, we already know that okay, the child has cerebral palsy, but what type of speech and language disorder or difficulty does the child have? We cannot but do a comprehensive assessment through different means of standardized scales to know the type of speech and language the child is having. So we collect case history, case as well. Then individual goal settings, as we know, individual are peculiar. So we cannot just say because the child has speech and language difficulty, A also has speech and language difficulty, I'm going to use the same approach to manage them. No. The management will be different based on their severity and types of difficulty they are having. Collaborative team approach. As we know, after speech difficulty, they might also have other difficulties as well. But the most common one is their difficulty in walking. So we also have AAs after the comprehensive assessment, after it has been done. So what are the evidence-based practices that we use in speech and language? So I actually limited it to just 4 or 5. So the first one is motor-based speech therapy. So what we do in motor-based speech therapy is that we use structured hierarchy organized tasks that break down speech into manageable motor patterns. For example, we can see the way, because they have difficulty initiating some sounds to the articulators not functioning as it ought to be. So this is a speech and language therapist here, and this is a child following an instruction. So particularly effective for individuals with motor speech disorder. Because of why do we do motor-based speech therapy? Most of children with cerebral palsy come down with severe drooling. So we use this to strengthen the muscles. We use this to strengthen the muscles for speaking. So require intensive, repetitive practice. It's not just a one-day thing that you do, but you do it repeatedly. Benefits include improved speech intelligibility, smoother transition between sound and better speech rhyme. Come down with feeding difficulty as well. So we do some of these therapeutic interventions for them. Target oral musculature strength, coordination, and sensory awareness to support their feeding. Some might even be dependent. Beneficial as a supportive component for children with oral sensory motor deficits. So enhanced preschool oral skills in infant, toddler with global developmental delay. It helps prepare oral structure for more accurate sound production. Okay. Move tongue to the left, right, pop lip, blow bubbles, say pee, smack your lip, and the like. So these are what we use. We also use tongue depressor. There are some that can't even do all this. They can't even do it. They can't mobilize their tongue. They can't move it to the left, to the right. They can't protrude it as well. So we also do some assistive devices for them. As we go on, we will see some of the assistive devices that we use. Okay, so we also have this to help them. These are device tools that we use. We also have modified spoon for them. As we know that some of them might come down with oral motor exercises. Why do we do it? Improve muscle strength, improve coordination, improve speech and swallowing, then improve language development. So we also use this as well. Augmentative and alternative communication, because our aim as speech and language therapists is for them to communicate effectively, either through non-verbal means, which is gesture. So we include this as part, because like she rightly said, some of these parents bring in their patients or their children very late. So we actually use this because there are some things that we should have done during the process of neuroplasticity, but we cannot really do that again because they are being brought in late. So we include this AAC, augmentative and alternative communication means. So on the device, there are a lot of apps that we can download on the app that will be useful for them. Okay, so we also have play-based language therapy. Use structure and semi-structured play activities to promote spontaneous speech. Use in a low-pressure environment. Engage turn-taking. You don't just be the one talking, you have to also make your patient or the child with cerebral palsy engage, feel among. For example, we have a consonant and a vowel too. We also have a consonant and a vowel. So the child says it. After saying it, you also tell the child as well to also give you an example of this. So it takes a while. It's not just a one-day activity. So particularly effective for preschool and early school age children, including those with autism, language delay, and social communication disorder. Build social emotional skills by embedding communication opportunities in cooperative play. So integrated interdisciplinary therapy. It is not just for physiotherapists alone. It is not just for clinical psychologists alone, but it involves all specialties. Involve collaboration with physical therapists, occupational therapists, teachers, psychologists, and caregivers to ensure consistent communication support across settings. Encourage holistic development by addressing speech and language goals alongside motor sensory, cognitive, and social skills. I've said this. Conclusion. Effective management of speech, language, and swallowing difficulty in individuals with cerebral palsy requires a comprehensive multidisciplinary approach that addresses the unique motor sensory, cognitive, and psychosocial challenges of each patient. Early intervention and diagnosis is very, very crucial. Collaborative involvement of physiotherapy, occupational therapists, dietitian, medical specialists, educators, and caregivers ensure continuity of care and optimizes functional outcome. These are my references. Thank you.
Thank you so much, Mr. Sotomi, for the lecture. We'll take the last lecture for the day, and it's from an occupational therapist. Please, with a round of applause, let's invite Mr. Akinsolu Peter to come and take this. Let's do better, please.
All right, good afternoon, everyone. So standing on this existing protocol, so I want to appreciate the coordinators of this program. Just that, like I said before coming up here, it would have been lovely if we have more of the special kids, we don't use disability for them. The special clients, we don't use patients also. I mean the CP clients being present, because my presentation is more tend towards the parents so that they will have something to do at home, because most time as clinicians, we focus more on what we can do in the clinic, and the home program, like my PT brethren would call it the home exercises, we don't place a lot of emphasis on that. And we know that when it has to do with motor cases like this, it's a long-term something, it's a collaborative. If you as a pediatrician, you do yours, the therapists don't do theirs, there will be no result. If the therapist does theirs, if the caregivers don't do theirs, there will be no result also. So it's like a circle. All right, so this is viewed from the occupational therapy perspective of the management of cerebral palsy. All right, so these are my outline. I'll be very brief. So I want to thank the pediatrician already. She did a lot of jobs, so I'll be skipping the medical stuff. But before I go, please, I want to say something here. In rehabilitation, as a rehabilitationist, there's what we call shared tasks. Shared tasks are what is common between one or two professionals in the field, and there are specific tasks that are owned by a given professional, and they are what we also call task shifting. When you reject your responsibility, other people are picking it up because there is no vacancy. So when you see me talking about some certain things, you say, but we also do this. So just know that either it's a task shift, you have left it, or it's a shared task. All right, first, who is an occupational therapist? Because this occupational therapist, occupational therapist is defined as a client-centered health profession with promoting health and well-being through occupation. Please, I want to say something here. I'm starting with this definition because I'm sure we are rare, because I think it's only my school for now producing occupational therapists. And if you hear, please, in the course of my presentation also, if you hear the word occupation, I'm not referring to your job. I'm referring to the things you do from when you sleep, from when you wake up, till you return back. Till you return back to your bed. Those are the things I'm referring to as occupation. I'm not referring to the job you're doing. Of course, your job is also part of the word occupation. All right. So the definition of CP has been given already, which covers the ICF definition of it, which has to do with sensorimotor activity limitation and participation restriction. These are also the type of cerebral palsy the pediatrician has covered that also. The presentation in terms of motor, she has covered that also, and these are the signs. For instance, let me just chip in this. You see the child as one of the, like she said, developmental delays, which is the typical sign of it you see. But before then, you will see the child only using one of the legs, maybe one arm, one leg. You see the child while playing, they are always crossing their legs. Always crossing the legs, or you notice on some sudden involuntary movements, as if the child is moving, but it occurs repeatedly. So these are other signs. Also, the end of the goal is not just to treat sensorimotor impairments, but to have them being purposeful in the society. Because one of the key limitations cerebral palsy patients have generally is what we call occupational dysfunction. They are not fixed into the occupation in the society. They are not doing anything, they are jobless. Even when some of them have a lot of these skills. So our areas is first, there's what we call play exploration. So we focus on play exploration, motor skill, fine and gross. So sensory processing and integration, cognitive and perceptual abilities, psychosocial and environmental factors. I know when the clinical psychologists in the house, we hear this now, like, okay, I want to hear your perspective about that. But just to portray this, as occupational therapists, occupational therapy actually originated from the mental health. So there are people who believe that occupational therapy should have nothing to do with physical medicine, but just mental health. So we are fully grounded in mental health. So before we now move to what people actually know us for, which is activities of daily living, and also assistive devices. If you have orthosis, orthosis and prosthesis in the house, we're also involved in assistive devices, but we don't do splinting. There are two different things in our field. Then home modification and vocational rehabilitation. So very fast. Now these are some assessment tools we use. From tomorrow when this patient comes, our client comes, so I'm going to be using these, evaluate them. So this is it. In occupational therapy, we believe that the occupation of the child is play. And there has been research that link a delay in play to a delay in cognitive, a delay in sensorimotor recovery, and a delay even in academic progress. For instance, we have several play classification. We have the Pegras play classification. We have the Taketa Epoch classification. For instance, if a child of 5 years old is still at the sensorimotor stage, beginning stage, and you are placing that child to be doing a symbolic play above the level of the child is not going to perform well. So that also, this is where we do play exploration, and we interact with the parents, the caregiver, and even the teacher. So that is why we also develop individualized education plan for these kids, so that their lecturers or their teacher will know the categories they fall into. So there are some kind of, so we do grouping for them, that this group of children, they belong to this play. So what is play? Play is self-consigning, intrinsically motivated, and driven by curiosity and exploration. Now, the child must lead the play. You don't tell the child the type of play to do. The child must lead the play. So play must be active, sensory, it can be creative, exploratory, imaginative, problem solving. So how do I play with my child? There is no specific way or how to play with your child. Just let the child take the lead. Let the child take the lead as often as they want to take the lead. Now, there is this thing about parents, that there is a particular stage. I'll get there when I'm talking about the psychosocial theory. When we talk about Sigmund Freud, psychoanalytic theory. There is a stage a child gets to, and they are very hyperactive. There is a play associated with that level. So we often see parents beating this kid and telling them to keep quiet, that you play too much, you do this, not knowing fully well that this is the level of play they are now in their developmental growth. So how do I play with my child? You don't need to constantly entertain your child. That is said, play is a child love language. Play is a child love language. Let me just chip in this. I remember when I was growing up, I didn't have the privilege of growing with my parents. So, you know, those days when parents live in the village, so you have to go to the city to live with people. So I didn't have that personal contact with my father. So until I've left secondary school and the like. So there was a day I went to the beach and I saw some kid playing with their parents, and suddenly I was crying unknowingly, because it's such that a lot of therapists or clinicians, I remember when I resumed my 400 level posting, the pediatricians, you look like her, she's a professor now, Olomo Teni, OATC, apart from Olomo Teaching Hospital. She will ask all the clinicians, whether you are physiotherapists or brain therapists, medicine, to dance. Your introduction to the pediatric class is dancing and entertaining the kid. If you cannot make any kid to laugh, you are not going home. So finally for me, I was laughing. Everything I did, they were busy crying, because there was something missing. There was something missing in my developmental house regarding play. You get it? So play is a child love language. So what I'm saying in essence here is that nothing should take you away from the child. Not money, not job. You need to create time to bond with these special kids and play with them, because as we go on, we see a lot of benefit of play. So and your play must be open-ended. Like I said, you don't restrict them. Let them make the choice, and don't change your toy too frequently, but let them have options to pick from. So when should I play? You can play with your child anytime you like, but money play helps children to transition into the day by grounding and regulating them. Why play before naps or bedtime? So this is it. Play in the morning and also before their bedtime. It may be a story you tell them and before bedtime. So there are several misconceptions about play. Some people just believe that play is just a break from learning. That is not true. According to Albert Einstein made a popular quote that play is the highest level of research for kids. Play is the highest level of research for kids. So when I have a developed milestone, the first thing I want to explore as an occupational therapy is the level of play of this kid or of these clients. So knowing fully well that now determines the level of activity I'm going to give. So if a child is delayed already in play with appropriate to age, to bring the child up to that level of play appropriate to age first, before even focusing on any other thing. So these are all misconceptions about play. There is right and wrong way to play. No, that's not true. Children don't know how to play. Adults must lead. That is not true. They know the things to use, but they know what they want to do. So that is why they feel like jumping. They may hold your TV to jump. because they know how to jump, but they don't just know what to use to do the jumping. All right. So these are stages of play. For instance, when we talk with special needs schools, we always have these. I always like to combine, this is Pegget, we also have the Taketa, I always love to combine it. For instance, imagine a child of 4 years old CP who ought to be doing constructive play at this particular time. At the age of 4 years, I should be able to tell the child a simple story, and the child should be able to give me a deducted meaning from it. Now, just imagine that a child of 4 years old is still at the stage of the unoccupied play, which in Taketa is called sensorimotor, still playing with kids, still playing with toys around. At this stage, they take everything to their mouth because they are high, they are looking for sensory. They are looking for sensation. They take everything to their mouth, everything. They want to touch everything. They can't differentiate between hot and cold. They just want to. So imagine a child of 4 years old is still there, and I'm putting the child in a nursery school. There's going to be a problem because there's a delay already in play appropriate to age. So I need to facilitate back first. So research supporting therapy efficacy, improving developmental outcome. For instance, a 2024 systematic review in Occupational Therapy International found that play-based interventions significantly improve motor skills, social participation, and emotional regulation in children with developmental disabilities. All right, what is in their play? Can you see the board? These are the things that are in their play. Math concepts, sensory integration, scientific exploration, focus concentration, physical development, social and emotional interaction, creativity and imagination, and language skills because they talk with their peers. They make those babbling sounds, those monosyllabic sounds. So this is when they do those things intrinsically by themselves. So play on the brain is an impact of brain, impact of play on the brain. But my focus will be on the hippocampus, because of the concept of neuroplasticity, because there is a special protein that is produced there, which is the brain-derived neurotrophic factor, which is an essential protein that is needed in neuroplasticity. So when you are playing with your child, or when you play age, we use the term age-appropriate play for the child, you are stimulating the hippocampus, which is for memory and for learning, and also what's increasing the production of that particular protein that will be needed when we're talking about sensory motor limitation in neuroplasticity. All right, motor skills now, which is fine and gross motor. All right, so a lot of them, they come down with, when we talk about movement, for instance, the basal ganglia initiate, the primary motor area, fine-tune it, the cerebral coordinate it in terms of movement initiation. So, for instance, there are several types of hand functions limitations they come with, and that is why when they go to school, they can't write appropriately. They find it difficult to write because they lack the appropriate hand function skills. Now, we have the hand function skills are divided into three. We have the in-hand manipulations, prehensile hand functions, non-prehensile hand functions. They are like 12 under it. So under assessments, there are things we can tell the patient, this is where your child is lacking. Stop beating the child. There is specific hand function the child is not having that is not making them to write appropriately or making them to write out of line, zigzag. So we also participate in school also where we teach these kids pre-handwriting skills based on these hand functions. But before we do that, there are certain things we consider in occupational therapy. We consider what we call activity analysis. In activity analysis, there are three things we consider. We consider first the patient or the client itself. We consider the functional level of these clients. Now, after you use your assessment, several assessment tools, so there are several classification, functional outcome measures you use. So you place these clients at a particular functional level. Then you consider the activity you want to give to these clients. Is this suitable to these clients? Should I upgrade it or downgrade it? Just like our physio, we say low intensity exercise and high intensity exercise. When do you do that? So then we also consider the environment. Is the environment suitable enough for this task I want to give to the child? Because there are some of them that can't perform any task when they are having sensory overload. We get to that place. They are not good with noise. They are not good with even lights, excessive lights. So we also have another thing we consider. We call it the rude approach. Rude approach states that, for instance, if you bring a spastic child to me as an occupational therapy, rude is telling me first that even though the end of my goal is purposeful activity, the first thing I should do is to normalize the muscle tone. Normalize muscle tone. If there are sensory impairments, I should also work on sensory integration for that particular child first, before I want to do any passive, any motor functions reactivation for that child. First, normalize muscle tone first. Because we know in therapy, for instance, in rehabilitation, one of the major devil we try to avoid when it has to do with motor impairments, whether in stroke or in CP, is spasticity. We try to normalize this first. These are then the next thing is biomechanical FRO. Now, this has to do with movements. This has to do with movement. Movement starts with flexion, for instance. So this has to do with me. Before I start with the child, I should take the range of motion, do muscle charts and everything. All those, I have all my data done. Then the car and shepherd approach, a floater approach. Now, these are all voluntary motor relearning approach. There is nothing compensatory in CP. If you use compensatory in CP, it will be difficult for them to regain voluntary motor control. And it is easy for them to gain voluntary motor control because of the concept of neuroplasticity, that the brain has the ability to adapt itself to internal and external changes based on the exposure to new stimuli or adaptations to correct injury. So we use Car and Shepherd approach that it talks about dual cognitive tasks, that you should carry out both motor and cognitive tasks simultaneously at the same time. That if you do that, the client has a better prognosis of recovering than when you just focus on motor alone. So there are some at home, the caregivers can do at home also as regarding this. Then the pediatrician has talked about this. This is the perimeter gross motor skills. These refers to stages. Then these are gross motor skills. Now, these are different gross motor skills. Now, remember, for me to put a child here, and again, this is why we must always refer back as therapists to the pediatrician first. Because if you don't have a definite diagnosis, you're going to have a wrong treatment approach. So, definite diagnosis. For instance, imagine a child that is having some seizures, some lesions in the somatosensory, in the parietal lobe, for instance. And all I'm focusing on is just the balance and the coordination. Not knowing fully well that even though this child may have, for instance, we do muscle shouting, they may have enough, let's just say 4+. Or anything from 4, they wish that their anti-gravity muscle is strong enough to initiate that movement. But fine, there is lack of coordination. But the major underlying factor is that they are having sensory disturbances. They may have issue with proprioception. They may have issue with depth perceptions. So I need to, but when I have a definite diagnosis, I will be able to know that these are the things I need to incorporate in my management and in my treatment. So each of these, we call them activities. Each of these things you see here, they serve a particular purpose and they are time-based for each of these kids. So you can see, for instance, now this child is doing this, by one is doing counting forward, there's counting forward, counting backward. This one is, for instance, when we talk about NDT, for instance, we'll talk about NDT, which is has like 3 principles of inhibition, principles of facilitation, and principles of functional and medicine activity. There must always be a central point of control. For instance, this particular one here, the central point of control is putting the 2 particular upper limbs behind without him looking back. So picking those balls from here to this place. For instance, as simple as cruising on a bed with bilateral use of hands, they find it difficult to do. So these are several hand function skills I want to achieve for a patient. For instance, it is not wise of you when you are doing hand manipulation for a child that does not have enough inside hand skill. It's not going to work. And this is where collaboration comes into place. So like there are different ones. Now, for instance, this kid here can easily pick this ball, can easily pick this circle with one particular length. This is spastic CP, for instance, can easily pick with one, but become difficult to pick with two hands simultaneously. Then it becomes more difficult when the child is doing midline crossing. So I've upgraded it. So these are all gross motor, ball throwing, high hand coordinations, and some of them, I remember there is one we have in our clinic now. When she first came, if you ask her to throw ball forward, all the balls were going backward. you see, we kept encouraging her, because one of the things we also fail to do is to explain the consequences of our treatment to them every day, the challenges that we face, so their mind is prepared towards it. And that is why in every center, they always ask them to see a clinical psychology first before they come to meet the therapist, so their mind is prepared for what they want. So they remove the load of this thing, patient and educator, educating them from me. So these are sensory processing. So there is this particular CP child also, quadriplegic CP. You know, that has to do with the cortical this thing, affectation. Now, when this child presented to us, the child could walk on smooth surfaces, but if the surfaces are rough, the child will start screaming. For instance, we have what we call our ball pool. If you put the ball in a smooth ball pool, no issue. But if you change the ball pool to the soft, to the rough ball pools, the child will start screaming. Because the child was hypersensitive. So we needed to do sensory re-education for the child, brushing, which we take him back again to NDT and root approach that said normalize muscle tone first and normalize sensation first before proceeding to purposeful and meaningful activity for this particular kind. So remember, everything we do around them, you must involve play. You must make it fun. And the more you make it fun, the more you are building more fibers of neuroplasticity, whether synaptic or neuronal or functional neuroplasticity. The more you are encouraging that, as far as they are concerned. So these are the sensory systems, like I've talked about. There are some of them that are sensory seeking. The sensory seeking, again, I can link it again back to the 0 to 2 years of play, where they want to touch everything back. Sensory avoiding. At this stage, they just want to withdraw from everybody. They withdraw from noise. Then sensory sensitive. There is this particular kid then that whenever you put on lights once, the child will literally scream. This is not autistic, this is cerebral palsy I'm talking about now. The child will literally scream. So when the parents discovered that they needed to change the bulbs in their house, and the child become comfortable. But for any reason, the child comes into here, the light goes off and the true light comes in, the child will just scream out once. So sensory sensitivity, then low registration. This is when they don't want to involve in anything at all. Now we'll see the consequences of these as we go forward and how to manage them. Then, in order to manage these sensory disturbances again, we return back to play again. So there are different treatment modalities I can give, all facilitating into play. They think they are playing, but at the initial time when they will present to the clinic, they cannot squeeze, they may not be able to touch these rough surfaces with their hands, these smooth surfaces with their hand for 1 minute, but now they are spending 30 minutes with it, they are spending 1 hour with it. So, for instance, these are common signs of sensory overload, covering of their eyes, anxiety, stress, fear or panic, physical discomfort, a lot of them. And these are techniques also to mitigate them. So this is where the caregiver comes in. We tell them, for instance, if I'm seeing a CP child, I always have a program for you. And if you don't, the next time you're coming to my clinic, you are giving me the feedback. If you fail 3 times, I stop seeing you because you are not serious. So there are things they can actually identify, just like nurses. Every other person comes and leaves the hospital, but nurses stays with the patient. So there are certain things, it is the nurses that discover that and relates to other people. The same thing like the caregiver, they are like the nurses of these clients. So what you see and what it means in sensory behavior, for instance, melting dance, for instance, now covering their eyes, complaining that it is too loud, or always talking, banging things and making noise, may be sensitive to sound and may try to avoid it. I may try to avoid others. I may seek out noise places that is quiet and calm. So So some people will think, I think this child is possessed, always leaving the family and staying alone. No, understand that your child is going through what we call sensory overload, and you need to learn how to regulate that for the child. Now, cognitive and perceptual abilities. Another domain of occupational therapy is cognitive rehabilitation, which is very, very key. Remember, when there's a cognitive deficit, it will be difficult for them. It will affect their education. It will affect their interaction with their kids. Even in their play appropriate age, everything will be affected. So cognitive is a major tool. 2025 meta-analysis in pediatric neurology reported that repetitive structured memory exercise, e.g. sequencing and recall. Now, when it comes to cognitive again, the activities are graded again. Because if you don't do your proper assessment, cognitive assessments, you will not know the level to start with from the child. So after your assessment, you know the level to start with, and you start building on that. And repetition is key. The same thing for neuroplasticity. Repetition is key for neuroplasticity to be formed. So mental health, this is where, like say with the clinical psychology also, they have to come in also and work with us also as a team. Then these are ADS. Now they can't dress themselves. The spastic is dyskinetic. They cannot dress themselves. Now we have several things fabricated that can help them to dress properly with ease. There are a lot of them. I just put some few pictures here. A lot of them, they can zip, a lot of them, this is a lady still doing her makeup despite being dyskinetic. You get it? There's a lot of them. We have to assist them. This is in the kitchen. This is cutlery they are eating. This is a double handle. This is mug for them. There's a lot of them. We just fabricate it for them. It's specific. There is nothing generic here. It's specific to a particular patient based on their diagnosis and based on their presentation. So this is their big room also. We do home modification for them. This is, like I said, it's an ADA and home modification so that they can be easily, remember the goal is what? Independence. For them to be as independent as much as possible. So these are things we fabricated in the house and co for them. This is a door handle. This one does not have in-hand manipulation, but this particular client has non-pre-inside and pre-inside hand function, so they can twist. So we give them something like that they can use to open their door. So the last thing is vocational rehabilitation. When we are done with all this, what is left of them in the society? What will they be using to make ends meet? And this is where occupational therapy also comes in. Now, there's what we call occupational profile in occupational therapy. Now, we assess the child and draw the occupational profile for the child based on the occupational profile. Now, remember, in drawing vocational rehabilitation, the child leads the interest. The individual leads the interest, not you. For instance, as I speak, there is one in OHCAC, there's one CP in OHCAC, there's one CP in UBTH, occupational therapy department, that was rehabilitated and employed as a worker in the department, working and earning salary and going up and up in federal government care also. So we also involved in vocational rehabilitation. Sometimes they will tell you they want to be a pilot. I have 2 minutes of it. It's too much self, thank you. So they will tell you they want to be a pilot. We say, no, you cannot be a pilot for now. These are the other things that are meaningful in life. You can also be. So we present them with the options and we rehabilitate them towards that goal. So if you come to occupational therapy unit, we have what people will call artisans, we have the carpentry section, we have the art and craft section, we have the
one combination for this company and this. All protocols need concern. In fact, let me start to appreciate all your money. Health officer, senior presenters, all who contributed towards the success of this wonderful program. We have learned that from the way of experience and experiences. May God bless all of you in Jesus' name.
Amen.
Now we are living in a global village. How do we get copies? You just had a copy of this wonderful program for those who are not in online. Another one, on Saturday we have sensitization on this. I don't know whether that sensitization will be enough to go all around to one and two for one sponsor. Another one, we have 17 local government areas that make up this wonderful state. This state now, as you have told us, I don't know the effort you have made towards reaching those and remote areas
of play that can protect a child's performance in school? And if there is, what is the solution to that? As a parent and as a guardian, or even teachers that are teaching this child. And question is there any level of play that can affect a child's performance in school? Then, if there is, what will be your action as a parent, a guardian, or a teacher? Then another, let me say, recommendation.
Education is directed to educational therapy. We actually saw a lot of pictures, equipment we use, but then in our environment, we don't get to see all these people. So my question is, in Nigeria, are there things we can provide to use for these patients where we don't have those advanced treatments?
I want to thank the presenters for the wonderful presentation. During my training in school, we had a semester course on speech therapy and occupational therapy. It wasn't very grounded, but having been here, I enjoyed the lecture and I have a few questions. So, of course, speech therapy. Mentioned in CP patients, about 70% of them come down with speech deformities. Do you have all of the patients in the subsystem, like you mentioned? Let's say they have a CP patient that has speech deformity. We have a patient in the respiratory, the laryngeal, and the other subsystems. Then the other question is, if they have this patient, what are the symptoms that you can use to say this patient has respiratory affection and PSP? And then the other thing as well. And the last question is, some CP patients, they have cognitive impairment. So when you are trying to participate in the exercise, you tell them, as you mentioned, then are not cognitively okay. You can't even be around. In that case, how do you initiate this exercise for participation? Thank you very much.
Members of the community to this program. My name is Mr. Assistant Director. I have 2 things, though I came late. If to say I come earlier, my first question couldn't have been asked. My first question was to Dr. Children. Sorry, I will say a little bit, take it back to causes of predisposing vascular. Secondly, can CP be detected during a qualifying life? Then the third question says, does CP clients have problem with urine and bowel control? If actually they have problem with urine and bowel control, do you think that they will possibly need continence care? Thank you.
That can predispose a child to developing cerebral palsy. In this part of the world, majorly perinatal factors like beta asphyxia. Remember, when a child is in utero, placenta does everything for the baby. The moment the baby comes out, that first breath, the first 1 minute, call it golden 1 minute. You know, it goes, as the air comes in, the lungs is filled with water as the placenta does everything in utero. So the moment the child cries, takes in that first breath, it goes to push out the fluid in the lungs so that the lung will start performing its function, oxygenation. And when that thing is lacking, that oxygenation will not take place. and the brain will be deprived of oxygen. And brain is the only part of the body system that doesn't depend on any other thing outside oxygen and glucose. The moment you deny brain of these two things, the brain is gone. 5 minutes is too long. The brain is gone. So bed asphyxia, when this baby does not breathe, get that adequate oxygen at birth, it can damage the brain. And if it damages the part that controls motor function, of course CP, it can damage the part that affects speech. The person comes down with speech. It does not mean cerebral palsy. If it does not affect motor function, it is not cerebral palsy, even if it was caused by bed asphyxia. Then neonatal jaundice. Unconjugated bilirubin is another neurotoxic agent that can destroy the brain of a developing, a growing child. So when this jaundice is there, it can damage the brain. When they are given birth, their hemoglobin level is usually high. Bladder neck are not functioning. So it's just depending on the extent of cognitive impairment present. But otherwise, the major problem of cerebral palsy does not come with that. I don't think.
You know, why I asked that question, this last question, there was a time when we had 3 abandoned babies in our world.
Yes.
So one of them, I don't know whether you met her, one.
Okay.
Adama, she was a CP client. Adama, the type of 2, she passed away. It was as strong as a camera. Very strong. All through that period, she was alive. And there was another time we also had a patient. As the both the local world was later separated in Operati, we had a patient with the same issue, constipation, strong stool. So that's why I begin to ask myself, does it have anything to do with bowel and bladder?
Okay. All right. They have, of course, feeding problems. If they are not fed well, it can lead to constipation. So it has nothing to do with autonomic control of the rectum and the bladder, like I said before. And then cognition. So feeding and the cognition, the child will vomit, aspirate some of them, respiratory infection setting. The child won't have enough to stimulate peristaltic movement, and then that after digestion, and they also having enough to be able to pass out, and that will be also enough to stimulate the peristaltic movement to push out the waste, constipation setting. If you don't feed with the right feed, when they come to me, I tell them, you see, give them enriched pap, no matter the age, especially for these severely affected, those that have up to grade level GMFSC, grade level 5, no matter irrespective of the age, give them enriched pap. In that pap, give not too watery, not too thick, add enough milk. I tell them the way they will add the milk and the age appropriate milk. Then blue band, I recommend blue band butter. You add it, the one that has dark blue color, you add it. The blue band is there to add oil, the milk is there protein, the pap is of course carbohydrate. The milk and the blue band, they're already fortified. Then you feed the child irrespective of the age. The age also guide you the frequency of the feeding and the quantity, and see them in the clinic. They're doing well. They don't need those curry, they don't need those yam, they don't need those rice. It's even a punishment because most of them they have feeding problem, showing the articulation parameters are not formed because of spasticity, so they can't chew. Peristaltic movement is not there, so they can't move down those hard things. So if you give them this semi-solid form, well enriched, you supply the things the child need, and you see they will pass out the waste very. So I think it dependent on the quality and the cognitive ability of the child. Thank you very much. So the articulation parameter come together and speak, and that's why you are hearing me. So for cerebral palsy, their problem is majorly around the articulation problem. So for those that are mentally sound, so they hear, if the problem does not affect the hearing parameter, they articulate it, they comprehend that receptive and then express. The articulation brings it down. Now, when I send them for speech therapy, I normally, in fact, anywhere in the world, I don't think they advise sending any child with CP for speech therapy at less than 3 years. Some people will tell you 3 years, but I personally, I send from 4 years. By that time, the child, development has really come up enough to be able to understand when you are speaking. If you, at 4 years, a normally developing child should be able to draw a person, which is the cheapest assessment tool we use for development, should be able to draw a child with at least 6 body parts. So at that age, okay, yeah, exactly. You count up to see. So at that age, the child can go for speech therapy. So that when you are given a structure, do all those things, blow bubble, all this, the child will be able to do that. Although, like he rightly said, they will first of all do their comprehensive assessment to know the type of tasks or how to channel the child in their program. So I think it should be from 3 years, the age that is expected that the brain development has already come up. But for those that have that are intellectually impaired, they also have the way they manage that. I think it has.
How can we improvise for the equipment that you mentioned?
Yeah, I think you have 2 questions.
Yes, that's the first one.
No, the first one is
The second one.
Okay, all right. So I hope I respond to your questions. The first one is whether can we improvise for, first, a lot of them are available here in Nigeria. It's just that a lot of healthcare practitioners have not been able to meet people who are into this specialty who can get them for you. And the ones we cannot get in Nigeria, let me say this, one of the intrinsic skill of a therapist is the ability to improvise. If you get to our gym today, there are a lot of equipment we don't have, but there are other things we use to improvise for it. So we can improvise for all of them, the ones we don't have, but we have a lot of them here in Nigeria. Then someone also asked, is there any level of play that can affect a child performance in school? I think that is the question. Okay, just that because of time, I didn't talk a lot about play itself. There are several components of play you get to look at. Number one is safety first. Is the environment safe for play? If the environment is safe for play, then let's now look at the components of the play itself. Now, one of the components of the play, because play evolves around cognitive and social development. That is the pattern of play. So you bring this play out. Now, this play I want to give to the child, is it corresponding with the cognitive level of the child? If the answer is no, you are giving sensory overload for the child already, and it will lead to frustration that they cannot do it. So you don't want to give them something beyond. It's like taking someone who is in SS1 to SS1 to go and write WAEC. You are just entering SS1, you want to write WAEC. You get, so that is a higher task. That's why I talk about activity analysis, where you examine the functional level of the client first, then before you look at the activity itself, then before you look at the environment itself. So it is possible for you to be given a play. For instance, a child is 4 years old, and the child, when you do play exploration, the child is still at sensory motor level of play, where they just seek things around, touch things, take things to mounts, like looking for sensory, they see like they want to touch it. And you are giving the child a dramatic play where they are meant to play a role and tell you the meaning. You know it's not going to work. So you are already frustrating the child, which will be harmful to the child already, because it will affect their self-esteem, their confidence, and it will make them to withdraw from everybody that they are not good enough. So play must be appropriate, not according to chronological age. You get it? But when you do your cognitive finding, then you place them based on the level of play classifications they want to give them. And that is why I keep saying it here. If you go to, for instance, I think that is common in the West, where you have these schools, they come for occupation therapy evaluation, where we give them individualized education plan. It's expensive though, because I remember about back in 2018, the one I did was 100K for one patient, because it takes a lot to access all this domain and now make the teacher to understand that the problem is not that the child is not intelligent, but you are giving too much information, or you are giving information above this level of the patient, and this is how to go about it. And they come out fantastic. If you don't do well, you are entitled to receive your money back. So I think I hope I've been able to answer your question.
The laryngeal side. Sorry. So from the laryngeal system, what are the things you see? Is the vocal cords. You know, there you have to produce sound, both voice and voiceless. So that's why it still boils down to comprehensive assessment. As a speech and language, you'll be able to see. You'll be able to see, and you tell the patient, do this, do that. You'll be able to know, okay, this sound this patient is producing, is it voice sound or voiceless sound? So if the sound ought to be voice and the patient is producing voiceless sound, then how system malfunction. Then for the phonation now, there are some sounds that ought to be pronounced orally, and you are noticing it through the nose. Then you should be suspecting the phonatory aspect that is faulty. You understand? And for the first one, the respiratory, the patient get tired. I wrote it there, fatigue. They will not be able to talk at length. So you should be expecting that. It still boils down to comprehensive assessment by the speech and language. You'll be able to check all this. Check the respiratory, check the laryngeal, check the phonation, and check the articulatory. I've been able to answer it.
Yes, thank you very much. The last question. I said some CP patients are cognitively impaired.
Okay.
And it's like there are some pictures that show where you show them some letters or sound and words to pronounce. So if they are cognitively impaired, how do you initiate or facilitate some of these exercises? Okay,
it still boils down to the AAC. So you can actually make use of the AAC to help them. And as an expert in the field, after assessing, you'll be able to know the level of activities they can do. Like what my colleague said, the occupational therapist, you'll be able to know that you don't need to fast track this thing. Because the person is 15 years does not mean that he or she ought to do the task of 15 years. Still boils down to early intervention. So you have to check all this and place the patient on the rightful task he or she ought to do. Don't forget, your aim, the speech therapy aim is for the patient to communicate effectively. So you can still start with but there are some processes you need to put in place to get to your long-time goal. I hope I've been able to answer it now.
According to the pediatric neurologist, we heard that they have different levels, severity levels. So you see someone with CP, the intellectual ability you are talking about, that person can go as far as higher education. You saw what we saw in the, what do they call it? The slides. Some can get up to university level, but there are some that cannot go beyond secondary school, even primary school, depending on the affected area and the severity. You get the point? So if we tell the family or the caregiver, look at the level this person is operating, or look at the level this person can go for, they are better settled with that. Is that okay? Okay, again, this moves us to the issue of handling the caregivers and the parents. Most work is on the parents or the caregiver. Practically, if we can handle the parents or the caregivers very well, we solve a lot of problems, because all these questions being asked here is what we say practically the parents are asking, and they are battling with. They are battling with this. And since they are not getting it right, you find out that from what the occupational therapist presented here, the social, you call it what? Psychosocial, whatever. List all of them. We just target the parents or the caregivers, and they have the burden. And if we don't get them well, the parents and the caregivers, the CP child suffer more because we are looking at environment. And this environment is the caregiver and the parents. Most of them come down with all sort of psychological problems, depression and anxiety. And when this is built up in the caregiver or the family, the end of it is the child suffering. But if they'll be trained, they understand the CP child very well, you find out that most of them do well.
I really want to thank all the speakers and the technical therapists, especially. The someone called me, but I couldn't be because I didn't want to miss a single thing of what he was saying. And I wish there were more parents. I actually think that what you presented is not just appropriate for sleep patients or for this session. It's actually appropriate for every parent. There are some parents who don't realize that play is actually something that children do. So we take care of our baby. And these days that schools are just buildings without fields for play. That is taken up. So I enjoyed this session. I wish we could repeat it and repeat it over and over. Let's say my main comment, or the story of the comment, is on collaborative care. There is something that we had talked about before at different sessions. It's like the theme for this program and listening to the presentations. The different presenters actually brought this towards the care of these children as as a city. Instead of having them come to me on a Tuesday and they go to her on Monday, maybe see the parents on the Thursday. Can we intentionally sit down, probably outside this room, and try to work out how to do this practically in the interest of the people who should benefit from it? Again, I want to thank everyone for bringing on the different aspects of the collaborative. Thank you.
The mothers in our CP community. Just to add to what Dr. Chidumere said, or the question she asked, the specialist with nutrition and dietetics, she's one of our facilitators for our parent support group. We've had her about 2 times in a year to come and speak to parents. And like I mentioned earlier, we have this CP parent group, support group that we have every other month. We call the CP parents together. And the recent one, Mr. Eric was here. He spoke to them from the clinical psychological aspect. He actually spoke to them, spoke to their persons, and many of them were in tears literally that day. So we have a CP community where we make this parent feel seen. This parent can relate to other parents who are in the same category as they are. They interact, they get some form of cushion, some of support right there and then. So sometimes after the meeting, we let them stay in the office for about an hour. So somebody will be expressing her own problems with the other person, and she who is more experienced will be able to share 1 or 2. There are a couple of times that mommy, as well as other parents who have children over the ages of 7, 8 years, give advice to other parents there who just had babies with CP recently about. So we have a very good community, a growing community, and we are working towards having it growing better. To answer a question from here, if we have a special school for CP children, currently in Abia State there is none, but we are pushing. We have a dream of having an ability rehabilitation center, a place that will bring children from all forms of disability spectrum, where they can come, get management care. At the same time, we also are trying to find a way to also include a vocational center that didn't just get therapeutic care alone, but other therapeutic care, they can also have some vocational training so that they can be positive members of the society. Yeah. Then to answer the 2 questions of mommy, that is why you are our government official here. All right. Yeah. Aside from the health work that we do radio jingles. Currently, right now, for this program, we have radio jingles going on Vision Africa and Flow FM. So if you tune in around 7 to 8 p.m. in the evening, you will hear our jingle today. If you tune in tomorrow by around 7:30 to 8 o'clock on both FM stations, you will hear our jingle from now, starting from yesterday, up. It will be up by Thursday evening. So we do that on occasions because of limited funding. So we are looking at funding that we can have these informations out on media outlets for people who can tune into radios to hear what we do, what CP is, and how to get care. Your second question is the health, what are we doing to get information to CP, about CP to LGAs around Umaya, the 17 local governments? Just recently, the health work, if you notice, some of the people that were in our health work were core members. Currently, we are in partnership with NYSC because they have core members across the 17 local governments. So we are currently in partnership with NYSC and we're trying to see how we can exploit this partnership to bring CP information to those local governments. So whenever they have this digital literacy for all awareness work, or they have the medical and health programs focused in all these local governments, we will send representatives from here, from Cerebral Foundation, to go to those local governments and also spread the information about CP and all the things that we do. We are also begging the government, because I know you take this message back to your commissioner. We are begging the government, help us to help these children, help us to help these families. This thing that you are seeing here, the CP program or CP parent support group that we have at our foundation, like I always say, only presents an iceberg effect. Currently we have over 75 families that we support in that support group. That is just a few people that we know. That's just a few people that we can see. There are thousands of other people that we don't know that have children with CP that are hiding those children in the house. And one of the things I feel we should take away from here is inter-collaborative care. If we don't have inter-collaborations cut across health workers, cut across developmental officials, even the ministries and policy makers, if we don't have that inter-collaboration, we will just be doing this thing on a very small scale. And this information and this help that is around may not get to the necessary persons. So please, ma'am, I hope you take this message back to your commissioner. Thank you very much. Mr. Tuchuku, please come and take the mic so I will round up.
Things we are saying here, majority of them, I practice it. I did not know anything about it, but God helped me to have patience and understanding. I'm the one born this my man, Francis. Francis did not talk, he cannot do anything. During the time, it is not easy for me because I have some salary challenges. So I understand that whenever you meet children, you will see something. I sent him to school when he was 10 years. He did not do anything. He cannot talk, he cannot walk, he cannot do anything. Then I sent him to nursery school. I used to use maths. Any place where they go, I will use the maths. He will be looking at them. So I told the teacher, whenever you are playing outside, bring him out. So from there, Francis was using like this, doing like this, making like play. He started calling, that's mommy. And God is very, very wonderful. Because when you have somebody like that, God will be telling you what to do and what not to do. We interact, we talk. Nobody knows what we are saying. And I always be with him. So now, Francis have finished primary school. He did primary school at St. Vincent de Paul, handicapped. Then we always go there every week to see him. That makes him to have family relationship. So we did not abandon him. Now everybody in my family loves him. We chat. we communicate, we do everything. Now, Francis have finished secondary school, but he cannot write. We tried it cannot go, but he can now press a phone. He can communicate with people. He can speak. No matter if you listen fine, you will understand him. But if he cool down, you will interact. Everything you hear, but if the thing come out being harmless or something like that, it can kill somebody with anger. So we don't normally allow him to be so pressure to have anger. So we show him love. Any place I'm seeing people with disability, I always send him there. They go when there and they interact, bring out. They always encourage themselves. They always encourage themselves. So at times, what I told you, you will not understand. When they go there and interact with others, he will come back and tell me, this my man told me that you should be doing like this and doing like that. I said, that's what I was always telling you, that you will be doing 90, stand like this, sit like this. Now he can manage to stand up and walk little. Praise the Lord.
My name is Dr. Kano Ngozi, and I'm a doctor with Regions Healthcare. Regions Healthcare is a multi-specialist tertiary health center healthcare facility located in Imo State. If you go on social media, you will see and hear about us. We're on Facebook, Instagram, Twitter. We're all over the place. We constantly make e-posts. So like I said, we're a multi-specialist hospital. It's multi-specialist in the sense that previously when it started as a stroke and neuroscience hospital. Now it has expanded to include not just neurology, the management of stroke. We also have specialists like cardiology, rheumatology, nephrology. The only thing that does not happen in Regions Healthcare is that women have not yet started giving birth. Every other thing happens. So when I heard in the complications of CP, some of the things that happens in CP, epilepsy, I say perfect. Our facility has a US-trained professor of epileptology heading our epileptology unit. So apart from the neurology part, that our MD, who is a triple board certified neurologist, neurocritical care specialist, and neurointensivist, who is US trained. We also have his wife, who is also a professor in epileptology. So center where Mr. Shotomi and Mr. Peter are
one deliverables we are going home with. One minute each. I don't want to call names. Please, let's volunteer and do it snappy.
My name is Abanku James. I'm a physiotherapist. Okay, I actually like what the presenters presented, especially the occupational therapist. The fact that we can have improvisation to all the pictorial presentations. I mean, I saw a lot of the white people just using it. I was thinking, is it only the white people that, have access to all these things? Can't it be replicated in our own area? But from the explanation, we can have access to it. So that is very good.
What I'll go home with is, I am reminded of CP definition, causes, predisposing factors, and the rest. But the broad point there is the management, which I was reminded that is multidisciplinary. It's not just only doctor, nurse, patient, or client. It involves other disciplines. Speech therapy, occupational therapists, dietitians, orthopedists, and the rest of them. And it is advisable, just as someone has suggested, if it will be possible for these clients, when they come once on a visit, all these therapists will be available to see them. Instead of Wednesday is for occupational therapist days, Monday is for dietitian, Tuesday is for orthopedic, stressing academically and otherwise. Thank you.
With the impression that CP clients should not be stigmatized, discriminated in the society, they must be treated with compassion, decency, and dignity. Thank you.
For formality, I'll start by saying thank you to everybody here for being here, to the health workers, my team members, and everyone. For me, particularly as a person, it was very exciting to just sit down like, every other person and enjoy the session. And I would say it was a very good time being here. For me, it was productive. And for I'll say our team members from Regions Hospital, right? That's how it's called now. Okay, I have heard so much about Regions Hospital. Just the other day, I told someone we should take a trip to Regions Hospital to actually see how the hospital is. And when Wilson said we're having people from Regions, I was like, okay, let's go there. That means the journey has actually started. And then Dr. Carlos said we'll find ways to collaborate. I mean, that's very exciting. And I'm happy we'll have to, as happened, to plan intentionally for these children. I'm actually happy that Abia State at this time has a government that is all-inclusive, I would say, and is really interested in children, not just children, in people with disabilities. And it just seems like this is the time to do the things that should be done. And I thank God for raising people here and there who are interested, who are keen into the vision, and who have the vision on their own. Thanks, everyone, for being here. And may God continue to help us to actualize the dream. Thank you all.
Of us that made our time to be here. We hope that when we call upon you again next year for the next August Bootcamp, you will honor us and be here again. And when next you are coming, you drag a member of your department along so that you can fill up all these seats here. All right, as we move out, please, let's go to the front of the chapel.
Okay. Good afternoon, ma.
Good afternoon.
How are you doing, ma?
I'm very fine.
Okay, ma. Please, can we get to know you?
Okay, I am Dr. Chidomere.
Okay.
Rose Ann Ifeyinwa, consultant pediatrician and a child neurologist working with the Federal Medical Center, Omahe.
Okay, that's good to know. So we want to know your area of specialist.
Like my introduction, I'm a child neurologist. I'm a pediatrician, and then the subspecialty is, I handle children with brain problems as a child neurologist.
Okay, that's a good one. Ma, what's the aim of this program?
The aim of this program is to emphasize on early identification of children with cerebral palsy and start timely intervention. Whatever you are doing for them, do it timely. You are bound to achieve a more positive result, and when you allow the child to grow older.
Okay. Yeah. So how do you feel about this program?
I feel excited, because people they respond. People that the invitee, you understand, they actually responded, and from the questions asked, it means that they understood the information and are ready to take it back, where it's mostly needed, because we try to emphasize on stigma cerebral palsy, because of their motor function, some of them, they are deformed. So not really good looking. So based on that, they are abandoned, they are stigmatized. Some people think it's a contagious disease, so we try to, make people to understand that it's not so, it's not contagious. They can still grow to bring out that potential in them if they are managed very well. And whatever you are doing for them, if you start it timely, early, intervention is the key. That's all. That's the message today. Early identification and early intervention, whatever interventional program you are doing for them. Like when we discuss define cerebral palsy, is a motor problem that has to do with muscle function you carry out with your muscle. So most of them are not intellectually disabled. It's just that motor disability that there's a problem. So you can still get them out to become somebody in the future. I displayed picture of some cerebral palsy who are medical doctors, lawyers, celebrities. So if we start whatever we are doing for them timely, we are bound to get them, to function.